Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to this special edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation across the child and youth healthcare community. And our goal is to spark conversation, ideas, and action. Since we're live, I want to remind everyone that while we don't take questions over the line, you can type your questions into the question box at any time. We'll check for the questions during the session and pose them to our speaker and coordinators at the end of the session. But go ahead and put them in as you think of them. We're delighted to be joined again today by colleagues from Paediatric Project ECHO at the Hospital for Sick Children. This time for infection control for children with chronic conditions in the COVID era. I would like to welcome our co-moderators for today, who will introduce the webinar and our speaker. Dr. I.L. Cohen, Program Head, Child Health Evaluative Services for SickKids Research Institute and co-founder of the Complex Care Program, Division of Pediatric Medicine at the Hospital for SickKids. Dr. Catherine Diskin is an Academic Pediatric Fellow in Complex Care. For those of you on Twitter, please tag us at ChildHealthCan and at SickKids News to any webinar-related tweets and share away. And it's my pleasure to pass the mic to Ayel and Catherine.
Thank you for the introduction. We're delighted to collaborate for this special session. For those of you who have not heard about Project ECHO before, Project ECHO is a virtual community of practice that aims to connect healthcare providers to share knowledge and best practice of care for children and youth. You will receive more information about Project ECHO, including how to register, after today's session in an email. It is our pleasure today to introduce our speaker, Dr. Michelle Syens. Dr. Syens is an academic clinician in the Division of Infectious Diseases here at the Hospital for Sick Children, and also an assistant professor at the University of Toronto. Since 2012, she's been the medical advisor for infection prevention and control and the co-lead of the Antimicrobial Stewardship Program at SickKids. More recently, she has joined the leadership of Public Health Ontario as a consulting physician for their infection prevention and control strategy and program. She has been involved in the response to this COVID pandemic, both locally as well as provincially and nationally, and is currently leading a multicenter study testing healthcare workers for antibodies of COVID-19. This study aims to get a better understanding of the natural history of COVID-19, in particular, whether the antibody response is protective and the duration of this protection, and to describe how the seroprevalence of COVID-19 is changing throughout the course of this pandemic. Thank you, Dr. Syens, for joining us today, and we look forward to your presentation.
Great, thank you so much, Ayel, and thank you to the group for having me here to present. So really, I was asked to talk about infection control in the COVID era. And so just to start, I don't have anything to disclose. And the objectives for the talk today are I wanted to review or discuss the current status of the COVID-19 outbreak worldwide in Canada and specifically in Ontario. I'm hoping to provide an overview of COVID-19 in children, including the presenting features and risk factors for severe disease. And then finally, I hope to review the infection prevention and control recommendations related to COVID-19 in both the hospital and community settings. So to start, I'm sure many of you have seen this slide from Johns Hopkins University. It shows the overall worldwide number of reported cases. And you can see as of this morning, we're over 2.5 million cases reported worldwide with over 180,000 deaths. You can see on the left-hand side, there's a summary of the confirmed cases by country and regions, and you can see the areas that are most impacted at the moment. So the US, as well as a number of countries in Europe, including Spain, Italy, France, and Germany. When you look at what's going on in Canada, so I apologize, this is from as of April 21st, so data's a couple days old, but the number of confirmed cases across Canada were over 35,000 with just over 1,600 deaths. So that's a mortality rate of just over 4%. And then if you look at the graphic on the right-hand side, you can see the distribution of cases across Canada. So Quebec is the most significantly impacted province at the moment with almost 20,000 cases. And then after that is Ontario with 11,000 cases. When you look across Canada, you can see that 77% are associated with community transmission now. So this is in contrast to at the beginning of the pandemic when most of the cases were related to travel or contact with the confirmed case. The hospitalization data from across Canada is estimated around 6.2% of cases are being hospitalized, with 1.6 admitted to the ICU. Mortality, as I already mentioned, is around 4.4% across Canada, with a significant portion of those occurring in long-term care homes and long-term care facilities. So how does this compare? How does our mortality rate compare to other countries? So some of the big population data is coming from China and Italy. So you can see overall the mortality rate in China was estimated at 2.3% and Italy at around 6.2%. And then you can see that there is a very large difference in mortality rate by age group, with significantly higher rates as you get over 60, 70 years of age. So if you focus on Ontario now, again, I mentioned the cases are just over 10,000 cases. About 42.3% are male, and a significant portion are over the age of 60, so around 44%. And in Ontario, a significant portion of those cases are actually coming from the Greater Toronto Area, so around 60% of cases, with a hospitalization rate of 12%. And so we've all heard about flattening the curve. And so this is data that was presented by the ministry a couple days ago, just showing where we are compared to other countries. So on the y-axis there, you can see it's the cumulative confirmed COVID-19 cases. And on the x-axis, it's the days since cases have surpassed 100. So the day that cases passed 100 was March 11th in Canada, and then March 15th in Ontario. So the gray line there represents the change for New York, and you can see the percent daily increase was quite high at the beginning of their course. The pink line is Italy. The red line is Canada, so our percentage daily increase is lower compared to the other areas. And then you can see Ontario there is in the blue. So it does appear that the cases are starting to level off, but I say that with caution. This is data also from the Ministry of Health, summarizing how we're doing with respect to ICU capacity, which was a big concern at the beginning, given the experience in China, Italy, and also in New York. So you can see here the red dotted line is the number of available ICU beds across the province. So this is Ontario-specific data, and each province and even states in the US have their own data related to what's happening locally. So this is Ontario, and you can see the red line is the total available beds across the province. The purple dotted line is the capacity with additional vented ICU beds. And then the blue bars are what happened in Italy, the projection from Italy, and then the pink line is are the actual COVID ICU patients. And so again, you can see that the number of ICU beds is below our capacity and appears to have leveled off. But again, I say that with caution because we know that in the long-term care facilities, those areas are significantly impacted at the moment, and there is a possibility that that could spill over into our acute care situation. So what about data on children? So this is the breakdown by age across Canada with the number of reported cases. So again, on the side here, you can see the age groups and then the percentage of cases that are in those age groups. So less than or equal to 19 years of age represent approximately almost 5% of the cases that are reported across Canada or confirmed with COVID-19. So this is lower than in the other age groups, but important to acknowledge that this may be an underrepresentation because we know that the testing strategies across different provinces and even in different areas of the US at the beginning were often quite targeted, looking at higher risk groups, and may not have had broader testing strategies to pick up some of the less symptomatic children that may be out there. And so overall, COVID-19 in pediatrics, just to compare how this looks with other countries. So again, in China, if you look at some of the big reports, about 2.2% of the cases were pediatric. In South Korea, 4.8%. Some of the preliminary data from the US, about 1.7% of the cases in pediatrics. In Italy, 1.6%. And as I mentioned, in Canada, the estimates are around 5%. So the Iceland data is quite interesting. Many of you may have seen the recent New England Journal of Medicine paper that was really describing the epidemiology of the pandemic there. And they looked at, so the first line there is targeted. So patients who were symptomatic and higher risk of disease were tested. And then the second line is a broader surveillance strategy where they were looking to test other sort of not the higher risk groups. And so you can see it when they did the targeted symptomatic higher risk group of the 9,000, just over 9,000 patients tested, 38 were children. So overall, that was 0.4% of the overall population, and 6.7% of children less than 10 years of age were tested. And then if you look at the surveillance, actually, they didn't pick up any children. So I think we're still understanding a lot about the epidemiology of COVID-19 in pediatrics, and a lot of our knowledge is limited by some of the testing strategies in different areas. So I'm going to move on now to talk a little bit about COVID-19 in children in the clinical presentations. And I wanted to start with a polling question for the audience. So which one of the following has not been associated with severe disease to date? So number 1, obesity, 2, cystic fibrosis, 3, asthma, 4, diabetes, and 5, older age. So which one has not been associated with severe disease? Okay, so most of you thought obesity, a number of you thought cystic fibrosis, and most people recognized that diabetes and older age were risk factors. So actually, I'll talk a little bit more about this, but the one area that has not been associated is cystic fibrosis, interestingly. So children typically, most of the reports are suggesting that children typically have mild disease, many of them asymptomatic. But we know that severe disease and deaths have been reported. Unfortunately, there's limited data on the risk factors for severe disease and death. But if you extrapolate from adult data and some of the risk factors for severe disease in children with other human coronavirus infections, it might be reasonable to consider that immunocompromised children or children with comorbidities such as heart disease, lung disease, neurologic disease, or diabetes may be at increased risk, but more information is needed. It's really quite limited what we have to date. There are some case reports about the children who have had more severe respiratory diseases and needed mechanical ventilation. And some of the underlying conditions that have come out in those case reports are congenital heart disease, hydronephrosis, and leukemia. But we really need larger data to get a better understanding of these risk factors. I mentioned already that in Canada, it's around 5% of the cases so far are reported in pediatrics. When you look at what's coming out from China, so many of you will have seen the report in pediatrics by Dong. And so when they looked at the pediatric cases and looked at those cases that had severe or critical illness, they found that 60% of those severe or critical cases were in children less than 5. They also found that children of all ages are susceptible and gender was not a risk factor. But I think we need to be cautious with the figures because many of the cases in this paper were diagnosed clinically, so we can't be sure whether it was actually COVID that led to the more severe illness. And if you look at the data from the US, so this was the recent MMWR, you can see they reported on 147 children hospitalized, 15 of which were admitted to the ICU. Again, there wasn't a lot of granular data on the risk factors in those children admitted to the ICU. They report that less than 1 year was the highest percentage of children hospitalized, but we don't have any information on the level of severity of those children that were hospitalized. And as many of you know, as pediatricians, you're often more likely to admit younger children and infants to hospital if they were to be unwell with COVID. So we're not sure what that means in terms of the severity. Anecdotally, though, it does appear that adolescents may be behaving more like adults. So from the data from New York, there are reports of obesity resulting in being associated with more severe disease. And from the Italy data, asthma and diabetes have been identified as risk factors, but interestingly, not immunosuppression or other chronic lung disease. So I think we're still early stages of understanding in pediatrics, and hopefully we will continue to get more information as things progress. Overall, if you look at the clinical features, so the Canadian Pediatric Society put out a good summary of the clinical features associated with COVID-19. It's a good summary. And just to highlight that you can see from the numbers there, not all children have fever or even cough with COVID-19, and isolated GI symptoms are possible. So you can see the numbers there. Diarrhea and vomiting, 11% and 9% respectively. I just put this up here. This is a good review on the clinical features of COVID for those of you who are interested. I like it because it doesn't review just the common symptoms, but also looks at and reviews some of the less common symptoms that have been associated. So one of those less common symptoms is the changes in smell and taste, which many of you may have heard about more recently. And then I'm not sure if anyone recognizes this picture, but it's been in the news quite a bit frequently, and it's been being referred to as COVID feet. So these painful swollen lesions that seem to be more often occurring in younger people without necessarily having a cough. So this is a newer phenomenon. People are gathering information on it and the possible association with COVID-19. So I'm going to move on and talk a little bit more about transmission and how the virus appears to be transmitted. And again, I wanted to start with a polling question. So which of the following statements is correct? 1, airborne transmission is common. 2, SARS coronavirus 2 can survive up to 3 days on surfaces. 3, approximately 50% of babies born to COVID-19 positive moms are infected at birth. 4, droplet contact transmission is common even when PPE is worn. So PPE including gown, gloves, eye protection, and face mask. And then 4, SARS coronavirus 2 has not been detected in the stool. So if you can fill out which one of the following statements is true. Okay, so most of you got the answer right. So I'm going to talk a little bit more about these, but SARS coronavirus 2 has been shown to survive on surfaces up to 3 days. So that was the correct answer. So just overview before I go into more details about the transmission. So COVID-19 is transmitted via droplets during close, unprotected contact. Airborne spread has not been documented for COVID-19, although it is an area that is the focus of a lot of research and ongoing work in that area. Aerosols may be generated during aerosol generating medical procedures, which could theoretically lead to transmission. Fomite transmission is likely, so that's transmission from touching contaminated surfaces that have the virus on it. While the virus has been detected in the stool and blood, the rules of fecal, oral, and bloodborne transmission remain uncertain. And finally, there is no conclusive evidence of vertical transmission to date, but more studies are needed, and I'll talk a little bit about some of the case reports that are suggesting that it may occur. So first of all, the evidence for droplet contact transmission. So there is a lot of data out there suggesting that droplet and contact transmission is the predominant way that this virus is spread. So the World Health Organization, their Joint Commission on Coronavirus Disease, when they went to review in China, they looked at over 75,000 cases of COVID-19, and the route of transmission was determined to be droplet during close, unprotected contact. So the majority of cases of COVID-19 have been linked to person-to-person transmission through that close direct contact with someone with respiratory symptoms. So that is by far what they found to be the most common way that this is transmitted. This was an interesting recent study further providing evidence of droplet contact transmission that came out in Emerging Infectious Diseases. So they looked at cases that were linked to a restaurant in China and essentially determined that the air conditioning ventilation likely contributed to droplet transmission. So infections were documented in 3 families, and you can see in the diagram in the left, A1 was the index and their onset of symptoms, and then you can see the other family members that were infected and the dates of their infection. And so they were sitting in close proximity for more than an hour. And on the right-hand side there, you can see the air conditioning unit and the airflow associated with that. And so what's interesting is that none of the other staff or diners in the restaurant were infected, which really suggests that airborne transmission was unlikely, and that this is likely close droplets and related to some airflow from the air conditioner. So what about COVID-19 and air sampling? What do we know about it? Studies have really inconsistently detected the virus in air sampling. So 2 of the earlier studies that conducted air sampling around confirmed cases did not find any of the virus in the air around confirmed cases. But more recently, there was a study where they were doing air samples in ICUs where they had patients with SARS coronavirus 2, and also on a general ward where patients with COVID-19 were managed. And so what they found was in the ICU areas, 35% of the air samples were positive and 12.5% were positive in the general ward. Most of these air samples were within 2 meters of the patient, which is generally what's considered for droplet spread, but one sample was positive at 4 meters away. What's really important to note is that the detection of the virus by PCR in the air does not mean that it is viable or transmissible virus. And so this study really got a lot of publicity. They were looking at the aerosol and surface stability of SARS coronavirus 2 compared to SARS coronavirus 1. And this was published in the New England Journal of Medicine. And they used a 3-jet collision nebulizer and fed it into a Goldberg drum. So essentially experimental conditions trying to determine if the virus could be aerosolized. And they did find that aerosols could be created experimentally, which supports the concept that aerosolization is possible under certain circumstances. So really likely in the aerosol generating medical procedures. They also found that the virus was viable on surfaces up to 72 hours. So again, this does not provide evidence that airborne transmission is occurring. It does provide evidence that under certain circumstances, aerosols may be generated. And this is really where the provincial, and this is our SickKids sign that we use, but the recommendations on personal protective equipment in Ontario. So the recommendation in hospital settings is for droplet and contact precautions for the routine care of patients with suspect or confirmed COVID-19. So that's a face mask, eye protection, gown, and gloves. And then enhanced droplet and contact precautions if you're doing an aerosol generating medical procedure. So that means an N95 respirator, eye protection, gown, and gloves. And of course, knowing that the virus can be viable in the environment, there's a focus on environmental cleaning, especially high-touch surfaces. So lastly, just wanted to mention quickly with respect to transmission around vertical transmission. Again, there are a lot of questions around this, and I already mentioned there's no conclusive evidence to date. And some of the larger case series from China and Italy haven't found evidence of vertical transmission. But we do have some case reports more recently suggesting that it can occur. And I've listed, there are 4 case reports there that talk about possible vertical transmission. The first 2 studies are based on positive IgM antibodies in infants born to moms with COVID pneumonia, but the NP swabs were negative. So it's really unclear the significance of that IgM antibody. The third case report there talks about 3 babies who were born to a COVID positive mom, who were positive on day 2 of life. And they report that they used strict infection prevention and control procedures during the delivery, but it's unclear what was in place to prevent postnatal acquisition. So a positive swab on day 2 of life, it's not clear that that's vertical transmission. The last case report, though, there does provide some more convincing evidence. So this was a baby born to a mom via C-section with COVID pneumonia. The baby was separated from the mom at birth, and then an NP swab at 16 hours of life was positive. So that is more suggestive that there can be vertical transmission. But the bottom line is it doesn't seem to be a frequent occurrence. And it would seem that in the cases where it's more suggestive that it has occurred, that they are from sicker moms, but more data is needed. And this is also an area of ongoing study. So another area I wanted to touch on quickly is asymptomatic infection and transmission from asymptomatic individuals, because this is an area where I get a lot of questions. And so asymptomatic infection, we know that does occur. We have cases where it's detected in the nasopharynx of individuals and they don't have symptoms. In China, the estimated percentage was around 1.2%, Italy 6.1%, and then from the Diamond Princess, some of the modeling estimates suggested upwards of 18% of patients were asymptomatically infected. And then when you look at the larger pediatric case series, it was around 13% of children had asymptomatic infection. What we don't really know is how significant asymptomatically infected individuals lead to transmission. So it makes sense that when you have symptoms, you're much more likely to be infectious. You're generating more droplets through coughing and sneezing. But there is some limited evidence to support transmission from people who are asymptomatic and never develop symptoms, and also from those people that are asymptomatic but in their incubation period. What's interesting is that most of this data comes from family clusters where they're really in close proximity to each other. So I think the bottom line is the presence of the virus in the nose does not mean that it's airborne transmission. It does need to get from the nose to the other person. And the likely way that that would occur would be from contact transmission. So touching your nose and then touching or contaminating the environment, which really means that hand hygiene is a very important component to prevent transmission from both symptomatic and asymptomatic individuals. Theoretically, droplet transmission could be possible, but again, droplet transmission, you generate many more droplets when you're symptomatic, coughing or sneezing. So the role of droplet transmission from the asymptomatic individual remains theoretical, and the extent to which it happens is unknown. So the bottom line is, with asymptomatic transmission, I think the important ways to prevent it are really washing your hands. And many of you will have seen this from Dr. Bonnie Henry. Wash your hands like you've been chopping jalapenos and need to change your contacts. So really just emphasizing the need for hand hygiene to prevent that contact transmission. And then physical distancing will really help if there is asymptomatic or symptomatic people with the droplet transmission. So finally, I've gone on probably a little bit longer than I had intended, but I wanted to touch quickly on infection prevention in the community. So as I mentioned, physical distancing is one of the main recommended public health measures, and the rationale is to reduce the transmission, the droplet transmission from both symptomatic and asymptomatic individuals. And our current guidance in Canada is a separation of at least 2 meters or 6 feet. And this has been adopted in most countries as a very important measure. But where there's a lot more controversy is with respect to masking. So I wanted to ask another polling question about whether or not you personally wear a mask when you're in public. Oh, so that's interesting. So 61% of you say no, and 40% of you say yes. And this may be, I know there's an audience from a broad range of places, so it may also reflect different local recommendations around that. So the next question is, for those healthcare providers, do you recommend to your patients that they should wear a mask in public? Okay, so about 50-50. All right, so as I mentioned, physical distancing has been a fairly well-adopted practice in most countries, but the masking has been more controversial. And I'll just provide some of the evidence and maybe give you some rationale as to why some people think it's a good idea and some people don't. So This is masking in the community. So keep in mind, in the hospital setting, if you're wearing it for PPE, mask, eye protection, gown, and gloves are important. When you look at masking in the community and some of the literature that's out there, so there are two reasons people can wear a mask. So one is to prevent the person wearing the mask from acquiring infection. And then the other potential use could be as source control. So if a person has an infection, wearing a mask to prevent that person from infecting another person. And so when you look at the studies, and there's I included a link at the bottom of the slide there, but from Public Health Ontario, there's a good summary about what we know about public masks. And it gives a summary of all of this literature. So looking at masks to prevent the person from acquiring infection in the community. So the studies that have been done are really cluster randomized controlled trials of households, where if someone in the household has an infection, most commonly these studies have been done with influenza, they've looked at masking household contacts or not masking household contacts and whether or not that's prevented infection in those household contacts. And the bottom line is, by masking the household contacts, it has not been shown to have a significant benefit to prevent infection in those contacts. And that's likely because there are other important measures like hand hygiene and physical distancing that play an important role in preventing transmission. So masking alone is not helpful in those scenarios, it doesn't appear. But if you look at when you mask the individual with symptoms in these scenarios, it does look like there can be an impact on preventing that person from spreading it to others. And we know that studies have shown that medical masks reduce the amount of aerosol and droplet shedding from symptomatic people. So it does look like there could be a role for masking in that scenario. But we do have to acknowledge that there are potential risks with wearing masks, especially if people don't know how to wear them properly. So if you are wearing a mask the outside and you do have infection, the mask can become contaminated. And if you are touching the mask frequently or not wearing it properly, you can contaminate other areas. And then there's also the risk of, if you're not washing your hands, you're wearing a mask, and the mask causes you to touch your face more frequently, that could lead to you self-contaminating. And so the bottom line with respect to masks is that they can serve as an important reminder not to touch your face. They can be a useful barrier to protect people in close contact with those who are symptomatic from becoming infected. They are helpful, or they may be helpful in areas where physical distancing is possible, but you really have to be careful and make sure people are washing their hands before and after handling their mask to avoid contamination. So many of you are probably aware of the Public Health Agency of Canada, as well as the Ontario province has now come out with recommendations around masking. And so they do say that the best way to stop the spread is by staying at home and avoiding close contact with others outside of your household, but that you can consider using a face covering to reduce transmission in areas where physically distancing may be challenging or not possible. So areas like public transit, smaller grocery stores, and when you're receiving essential services. So I will end there and turn it over to questions.
Thank you, Dr. Sines, for this excellent summation. We will now open up for questions. I just want to introduce a few other colleagues from the complex care team at SickKids who are going to join us for the discussion. Dr. Julia Orkin, who's the medical director of the complex care program, Michelle Ho, a nurse practitioner in the complex care program, and both of them co-lead Project ECHO. Jazz Odo, who's a clinical pharmacist, Ashley Edwards and Kathy Netton, who are social workers, and Erica Gibson and Jordan Bolio, who are registered dietitians. So we're going to read out some of the questions we've already received and try to get through as many as we can in the remaining 20 minutes that we have.
Okay. And the first question I think I'm going to ask you, Dr. Cohen. Okay. Are there any specific recommendations for families who have nursing support in the home, recognizing the need to physically distance?
So it's a really important question. I think probably the most important thing to emphasize in terms of infection control in the home setting for families who receive nursing support are a lot of the generic measures that Dr. Sines mentioned: washing your hands, keeping physical distance, making sure that coughs and sneezes are covered, and cleaning and disinfecting whatever high-touch objects are in the home. A couple of ones unique, I think, to the home care setting are screening people who enter your home to make sure that anyone who enters the home is well prior to entering. In terms of our experience as a program during this pandemic, one thing that's very clear that we've learned more, I think, from the adult sector than the pediatric sector is that we need to work really closely between the hospital and community sectors so that we have optimal infection control practices for people receiving care. In terms of children with medical complexity, again, as Dr. Sines alluded to, these are really early days in terms of what we're learning, but they're certainly recognized as potentially a vulnerable population, not just for getting infected, but also for spreading the infection, given things like that, the fact that their baseline clinical care often involves aerosolizing medical procedures like non-invasive ventilation or tracheostomy care and other things. So what we've been doing as a program has been really trying to support an rapid deployment of policies, procedures, and processes that help prioritize the safe delivery of care that's sustainable for children with medical complexity across all sectors, again, anywhere from the community to the hospital. And the particular settings that have been the highest emphasis in the communities are those in which there's congregate care. So places like group homes, respite facilities, et cetera. Those are the ones that we know from some of the from some of what's happened tragically across the country, where spread can occur most quickly.
And I might just add to that Children's Healthcare Canada are hosting a webinar next Thursday on the challenges and solutions for delivering home care and respite services during COVID-19. And related to Dr. Cohen's answer, we've received a question that I might direct to Ashley Edwards, one of our social workers. How do we support families when information is evolving so quickly?
Hi, Catherine. Can you hear me okay?
I can hear you.
Okay, great. So this is a really interesting question. I think not only because information is evolving so quickly, but everything around COVID is evolving so quickly. I think it's, for a lot of us, it's brought about pieces of questioning the fragility of life, how quickly life as we know it changes, and often leading to some existential questioning as well. Kathy, my colleague in complex care, one of the other social workers, we're privileged to be able to provide mental health support to families throughout this COVID experience. We're just talking about this yesterday and how unusual supporting families is right now, because we're also living in the midst of the COVID pandemic as well, and adjusting to how we're coping and processing this as well. So it's a really interesting, I imagine many other healthcare providers are experiencing this too, that you're struggling not only how to support families, but perhaps feeling counter-transference or an emotional reaction to what is being said because you too are experiencing it. In terms of that, we see families and ourselves experiencing loss and grief, but also balancing the regular life experiences. So we're dealing with this, pre-trauma experience, range of responses of hope and grief, loss, sadness, anger, and joy, but also dealing with the quote-unquote normal life stuff that exists pre-COVID. So family conflict, managing teenagers for our families in complex care, dealing with children who have high medical fragility, and also just thinking about vulnerable children, particularly women, who may be in unsafe environments at home and what that means. In terms of trying to be concise, which isn't always my strength, I'm trying to think of practical advice to provide to other healthcare providers and how they support families. And I often think about, for social workers, we talk a lot about narrative therapy, how while this is still occurring, there's other pieces of life that still continue on, and how to ascribe meaning to experiences. So not to ascribe meaning to the pandemic necessarily and negate emotional experiences, but how do we find purpose and reason to keep going? When we look at other trauma therapists, Dr. Bessel van der Kolk, social workers such as Brene Brown, they talk about the importance of encouraging predictability as a protective response. So in terms of supporting families, helping to establish routines, encouraging connection with others, and also trying to encourage a presence in the current moment. So there's many different ways to achieve that, be it through mindfulness, sometimes just breathing, music that is just supportive and grounding for people, reaching out to colleagues or family or friends, which can be difficult at a baseline for many of our families in the complex care program. Although we've heard an interesting piece too from some of our families acknowledging that other people now know what it's like to be isolated and more alone. So really interesting pieces and lots of resources out there. And I could probably talk for hours about this, but I'm trying to be mindful that other questions exist too. So just also in knowing what resources are available in your local community through mental health support, not only for the families you're supporting, but also for you as clinicians as well.
Thank you, Ashley. And we're really excited by the number of questions that we're receiving, and the questions that we don't get to answer during this question and answer session. We will prepare an FAQ document that will be published on the CHC website after the webinar. And so, Dr. Cohen, I might go back to you with this next question, which has popped up a little bit. With how does the recent evidence of asymptomatic cases in children affect how we should see children for problems that are not COVID related in the community setting?
So excellent question, not an easy one. So I probably should preface this, and probably all of us when we answer any of our questions should probably preface this in saying that whatever we answer today may change very quickly as new information emerges. The current recommendation for office-based practices, including primary care, is to screen and triage appropriately, do as much virtual care as possible, and to only see patients for essential appointments such as newborn care and vaccinations. Although more and more is emerging that it's not just we should only see for essential care, but we should ensure that we deliver essential care, because foregone care is a major risk, and there's a lot of data emerging that that's happening in Canada and elsewhere. Many offices, I think, have signs on their doors and do pre-screening phone calls. Some have installed some of the barriers, like plexiglass barriers that you've seen in some of the retail sector, like supermarkets and pharmacies. But the key recommendations are, again, a lot of them very similar to what I answered with your question about home care, maintaining physical distance, putting patients at least 2 meters away from each other in the waiting room, making sure that there's hand sanitizer available, and trying to minimize the number of parents who come with patients to clinic visits as much as possible. Those are the recommendations that are in place now.
Thank you. I think the next question is probably best answered by Jazz Otal, who's our pharmacist. It's a question about the use of MDI, epinephrine, in the setting of croup, which is a change in practice.
Yeah, obviously, this is something that's not standardly available on the Canadian market, nor is it part of the existing Health Canada Special Access Program, but rather, given our concerns with aerosolized therapy and in the setting of COVID, institutions can contact Health Canada for the steps on obtaining special urgent approval to procure or obtain the MDI or meter dose inhaler dosage form. In our experience, and I'm sure everywhere, supply is quite limited. So in terms of actualizing and operationalizing it, it will be a heavily conservation strategies will be very important. The Canadian Paediatric Society statement does on acute management of pediatric COVID discusses the risk of aerosolization, and obviously with all of our other respiratory conditions, there's been a shift to using MDIs in aero chambers or dry powder inhalers. For severe croup, the CPS statement says that nebulized epinephrine can be used, provided that full PPE is available and that all airborne precautions are taken. And of course, the alternatives would be MDI if accessible at your institution, or subcutaneous or even IM epi. The issue with the meter dose inhaler for epinephrine, used specifically for croup, is that evidence is extremely limited. And particularly there, if you do a literature search, it doesn't really shed light on how to dose the MDI formulation for non-asthma indications. So the CPS statement does have suggested dosing, and internally at SickKids for our formulary, we've also done a review, and much of it is extrapolated from other conditions or inferred from bioavailability studies with other dosage forms. So realistically, the MDI use may not be as predictable in terms of its response, and there may be an element of titrating to clinical effect when you are using it.
Thank you. And for Dr. Science, there's questions about whether we should Lysol off the cardboard boxes for things like Amazon deliveries. So should we be disinfecting deliveries that come to our houses?
So that's a good question, and I definitely get it a lot. People are always asking how to protect their family from bringing the virus into their house. So I guess I would start by saying by far the most likely way the virus will be brought into the house is from an individual coming into the house. So with that in mind, the physical distancing is really important. And if someone does need to come into the house, making sure that they don't have symptoms and are practicing good hand hygiene in the house. But with respect to the cardboard boxes, we know in theory, and I spoke about it in the presentation, that the virus can live on surfaces, and on cardboard, I believe it's up to 24 hours that it can be on the surfaces. So there are two options. One option would be to put the cardboard box away and open it at a later date. Another option would be to open it and discard the box, and then immediately make sure you're performing hand hygiene, washing your hands to prevent transmission or bringing anything into the house.
And related to that question is one about the risks associated with washing food. I wonder if Erica, our dietitian, might comment on that.
Hi, Catherine. Thank you. I think the risks associated with washing food, there's been some data to suggest that the transmission of COVID is not happening through infected food. So I know some people have been using precautions such as washing food with soap and water. And our recommendation at this point is to not use soap and water for washing food. The reasoning being that the soap used for food could potentially lead to GI upset, vomiting, diarrhea, that type of reaction. Additionally, our current recommendation is just to continue practicing good hand washing prior to eating, and to rinsing any food with water that is potable, and using that before eating or consuming. And any food that will be cooked, the cooking process would kill any potential virus as well.
Thank you, Erica. And another question, as we're coming to the end for Dr. Science, is whether or not we, I guess, as healthcare workers, what we should be doing about our clothes to prevent spread to our families.
So another good question. There are some good sort of infographics out there about how to stay safe. So things you can do before work, during work, and after work to try to help keep you and your loved ones safe. So I would refer people to some of those documents. Some of the suggestions before you go to work are to make sure you're wearing fresh laundered clothes to work, and potentially bringing a change of clothes to wear home in a washable bag, making sure you're only bringing essentials to work and not bringing a lot of stuff to work that you have to then bring home to work, and then some strategies during work, making sure you're wearing appropriate PPE and hand hygiene before and after contact. And then when you're going home from work, some strategies like putting your clothes in the hospital laundry or a washable bag, disinfecting footwear, or having footwear that you wear to work and different footwear that you wear home. So there are a number of different strategies. In the interest of time, I won't walk through all of them, but those are some of them. And just emphasizing again that the hand hygiene is probably one of the most important strategies.
So I'd like to ask a question of Dr. Diskin, which I think is one that we've seen quite a lot, and I think is an important theme for today. So personally, someone else asked this, but it's an issue for me as well. I actually found it really hard to stay up to date with all of this, because A month ago, we were told that wearing masks isn't helpful, and now the evidence has changed and the recommendations have changed. There's lots of examples like that in a new emerging infection. So where should I go in 2 weeks' time when we don't have Dr. Science available to us to give us an update to know whether this has changed again?
We've definitely had conversations within our group about identifying trusted sources of information, recognizing that information is changing very quickly, and also what's practice here in Toronto and Ontario might be different from where other people are. So where we are recommending that the healthcare professionals that we work with, myself, and also for families, is for Toronto, we go to Toronto Public Health. For Ontario, we look at Public Health Ontario or the Ministry of Health. And we'll include all of these in information that you'll receive after the webinar, because we think it's just so important. In Canada, there's Health Canada, and worldwide, Johns Hopkins is a good source of information. Dr. Science shared that on one of her initial slides, the Centre for Disease Control and World Health Organization. And I think the points that Dr. Cohen has mentioned already about staying up to date, knowing that information is changing and going to trusted sources of information is actually really important in a time where things are changing. We have a similar curated list for families about trusted resources. So we refer families to the About Kids Health, which is our website here within SickKids. I know that our colleagues in CHIO have a similar one. And I think it's again about emphasizing in conversation the role of trusted information. So I think
so thank you everyone. We'll end on that note. Just want to thank everyone for attending today's session on infection control for chronic conditions in the COVID era. We're really, really lucky and fortunate to be able to have such a wonderful platform to share our learnings during this really difficult time, and allowing us to have a really rich discussion about these important issues. Particular thanks to Dr. Science for providing us with such wonderful information in her talk, and also to everyone who participated in the discussion. We'll do our best to try to answer as many of the questions as possible offline after today's session is finished. We want to also thank Children's Healthcare Canada for this incredible collaboration. We will compile a comprehensive list of resources and some literature that was mentioned today during the talk and the Q&A, and you'll receive that by email shortly. And all of this will be posted online on the Paediatric Project ECHO website, as well as the Children's Healthcare Canada website. So thank you, everyone. Have a wonderful and safe day.
Thank you, Ayel, Catherine, and Michelle. Typically, Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 Eastern. However, during the COVID pandemic, we're offering special editions of some of our knowledge sharing opportunities. These may fall outside our typical webinar time slots, so to stay up to date with all of our activities and events, please sign up for our Children's Healthcare Canada Spark newsletter if you have not already done so. And it's always great if you watch live, as your questions and comments really enrich the discussion. But if you can't watch live, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network, where we'll also post some of the FAQs and other resources. We are excited to bring you two COVID-related webinars next week, and you heard about one of them from Dr. Diskin. On April 29th at 11 Eastern, we'll be co-hosting with the Canadian Pediatric Society Acute Management of Pediatric COVID, and we'll be joined by the authors of CPS's most recent publication, their practice point on the acute management of COVID-19. And on April 30th at 12, we'll be joined by home care and respite care providers for the webinar, Challenges and Solutions for Delivering Home Care and Respite Services During COVID-19. So thanks again for joining us today. Thanks to Children's Healthcare Canada member, the Hospital for Sick Children and its Learning Institute, as well as Paediatric Project ECHO. And we hope to see you back here on April 29th. Bye, everyone.